Ortho, and today we're going to talk about shock, right? Shock is a very important topic, very commonly asked, and very important for managing patients in ICU and in the emergency as well. So basically, shock can be classified into various types, right? It can be classified into hypovolemic shock, which we most commonly see in orthopedics. Hypovolemic shock means the volume, that is the blood volume, is reduced, and therefore this shock occurs. So hypo, reduced volume, hypovolemic shock. The second most common type of shock that we see in orthopedics is septic shock. This is probably because of an infection or a bacteremia or some kind of inflammatory response in the body causes a septic shock. Then we also have what is called as a spinal shock, which we will learn more in detail in the spine trauma portion. And we also have a cardiogenic shock where the heart fails to pump blood, right? So we will not be dealing with these shocks in detail. Today, let us focus our attention on hypovolemic shock and a little bit about septic shock as well. Spinal shock will be dealt in another video along with the spine trauma chapter. And cardiogenic shock, all of us know very well, it is because of poor pumping of the heart or heart failure, and this probably does not concern you in detail for your exams and clinical life as well. To deal with hypovolemic shock, and all of us know very well that an adult male of 70 kgs has about 4.5 to 5 liters of blood, right? So what happens when this blood loss starts to happen? This is best discussed in the form of a table. So there are 4 different classes: class 1, class 2, class 3 and class 4. That is divided into 4 different types based on the amount of blood that is lost. In class 1, less than 15% of the blood is lost, or less than 750 ml is lost. In class 2, 15 to 30% of blood is lost, or 750 to 1.5 liters of blood is lost. In class 3, 30 to 40%. This is a very important table for you because this is what is usually asked very commonly in exam, almost repeated in every other exam for your theory. And in class 4, it's about 40%, more than 40%, life threatening, more than 2 liters. In many cases, most of the patients will not survive this kind of blood loss in class 4, right? So what is the heart rate that you see in each of these patients? Very important. The heart rate and BP is normal in class 1 because the body compensates for the blood loss. The blood loss is not so heavy, so the body compensates for the blood loss. In class 2, the BP becomes more than 100, the heart rate becomes more than 100, whereas the BP is still normal. In class 3, the heart rate goes about 120 and the BP starts to become less. The body is not able to compensate, or the heart is not able to pump enough blood at enough speed and number of beats per minute to be able to compensate for the blood loss. In class 4, it is 140, more than 140 heart rate, and blood pressure is tremendously decreased. So that is very important. We all know about urine output as well. What happens to the urine output in each of these cases? The urine output in class 1 is more than 30 ml per hour. In class 2, it is 20 to 30 ml per hour. And I go to class 3, because the kidney is less perfused, the less amount of blood flowing through the kidney, it is almost negligible. So if a patient is in prolonged class 4 blood loss, the urine output is almost negligible. So in class 1, from 30 milliliters per hour to negligible in class 4. And all of us know how is the mental state of the patient. The mental state of the patient in compensated stages, that is in class 1 and 2, the patient is reasonably all right. Little anxious maybe, but otherwise reasonably all right in class 1 and 2. In class 3, the patient is very lethargic and irritable. And in class 4, the patient may be in coma or completely unconscious, right? So let us recap. This table is very important for your to be able to reproduce in the exam. Hypovolemic shock can be divided into class 1, class 2, class 3 and class 4. Class 1 is where the blood loss is less than 15% of the total volume, that is less than 750 ml. Heart rate is normal, blood pressure is normal, body is able to compensate for the blood loss. Urine output is usually more than 30 milliliters per hour. The patient is anxious and the pH is also normal in this case. In class 2, right, when the blood loss becomes progressively higher, 15 to 30% of the blood volume loss occurs in this variety. About 750 to 1.5 liters of blood is lost. And here the body is not able to compensate with so the heart rate increases to increase the perfusion of the limbs and the other parts of the body, including kidney, brain, etc. So the heart rate increases to more than 100. The blood pressure is still maintained normally. The urine output is 20 to 30 milliliters per hour, and the patient is anxious and a little bit irritable. In class 3, when the blood loss progressively increases and the patient loses 30 to 40% of the blood, about 1.5 to 2 liters of blood, the heart rate increases to more than 120, and the blood pressure is decreased. In this case, the heart is not able to, or the circulatory system is not able to compensate. Output further decreases 5 to 15 milliliters per hour, and the patient is lethargic and quite irritable. If the blood loss becomes more than 40%, it is called as class 4. There's more than 2 liters of blood loss. Heart rate is more than 140. BP is tremendously decreased, and the output, urine output, is negligible. We have seen this in many patients with severe multi-polytrauma patients who have negligible output and they are almost in coma. So this is a very important table, very important to reproduce in your exam. How do you resuscitate these patients? Resuscitation of a hypovolemic shock patient. One, you have to give isotonic solution. You have to make 2 IV lines. First thing, when the patient comes to the emergency, 2 large bore IV lines, and an isotonic fluid must be started, like normal saline or ringer lactate. These 2 are isotonic solutions must be started. Blood must be started as early as possible in class 3 and 4. Here we can use an O type donor, which is a universal donor, right? O negative donor, which is a universal donor. Then we can type specific blood, cross-matched blood can be given after the patient is stabilized. We should be able to give red blood cells, platelets, and plasma in a 1:1:2 ratio must be given, and we should resuscitate the patient. So how do we know that the patient has been resuscitated? These are the findings which you'll see in a resuscitated patient. One is the urine output increases to 30 to 60 ml per hour, that is 0.5 to 1 ml per kg per hour. Right, so this is an indication of the patient has been resuscitated. The serum lactate should come below less than 2.5 millimole, this millimole per deciliter. This indicates that perfusion has been achieved in all the organs and all the limbs. That is why the lactate level has come down. The third thing indicative of resuscitation is a gastric pH. This can be measured. This is more very sensitive criteria. A gastric pH, when it returns to 7.4, it indicates that the patient has been revived or resuscitated. Then the base deficit. The base deficit should be between -2 to +2. So this can be done by an arterial blood gas analysis. So these are the 4 things that we see to check if the patient has been resuscitated from a hypovolemic shock. Urine output should reach 0.5 to 1 ml per kg per hour, or let us say 30 ml per hour. Serum lactate should be less than 2.5 millimole per deciliter. Gastric pH reached 7.4. Base deficit should be between -2 and +2. This indicates that the patient has been resuscitated sufficiently. Right, now let us go to what is septic shock. Septic shock is a type of shock where the end organs and the limbs are not being perfused appropriately. Why are they not being perfused appropriately? Because there is a decrease in the vascular resistance. So there is a loss of pressure, decrease in the vascular resistance. That means the blood vessels are not able to contract, and because of which the pressure is not maintained, and therefore the blood flow through it is reduced to the end organs. So this happens in a septic shock. Why does this happen? This happens in 2-3 conditions. In an inflammatory response, can be some kind of a sudden inflammatory response, or could be initiated by an infectious inflammatory response. So the most commonly that we see in orthopedics is an infectious inflammatory response. So let us compare and contrast. Between septic shock and forgive me, I'm just adding a slide. Septic shock and hypovolemic shock. So this is septic shock, and then we have the hypovolemic shock, right? The major thing is systemic vascular resistance is reduced in septic shock, whereas it is increased in hypovolemic shock. The body tries to compensate by increasing the vascular pressure, but whereas inherently the pressure is low in septic shock. This can be measured in the CVP, or central venous pressure measurement can be done, and this is the basic difference between the septic and hypovolemic shock. One of the most important differences you would see. The cardiac output is increased in hypovolemic shock, increased in septic shock, and it is decreased in the hypovolemic shock. Mixed venous oxygen is increased in septic shock, and it is decreased in hypovolemic shock. So these are the 3 main differences between septic shock and hypovolemic shock. We will, if an opportunity arises, we will discuss septic shock in more detail. But you must know everything and anything about hypovolemic shock. I hope this helps you with your questions on hypovolemic shock. Thank you. Hypovolemic shock. This is Dr. Kannan from Plexus Ortho. Thank you very much. Yeah.